during a bronchoscopy procedure. Okay. See, some of these look epithelial. More epithelial. It's good to know the path the needle took, because sometimes now, if we're looking for groups, this is going to really throw us off, right? And I'm going to say, wait a minute, we shouldn't see groups in a lymph node. But if you go through the lung, you're going to pick up lung cells, right? Lung tissue. Oh my God, there's all kinds of respiratory cells here. Look at this. See? Beautiful. Ciliated. Look at that cilia. Lovely. Okay. So yes, we definitely went through lung. Okay. So now it's going to be more tricky because we have lung epithelium and it's going to be tricky. Did they get a lymph node? Were they in the lymph node? Really? That's the other question now. We have so much contamination. Were we even in the lymph node? Right? That's another thing. So are these lymphocytes? Some of these. So I'm again respiratory, probably respiratory, because they're kind of stuck together there. How about these guys?
This one is lymphocyte.
Lymphocyte, but look at how few they are. See that? So this is where you have to start saying, did they get a good lymphoid sample? Why are we getting so much contamination? Okay, so there are a few lymphocytes. Yeah. Are they mixed or monotonous?
A little bit different size. Lymphocytes.
Mature?
Yeah.
Less mature?
Yes.
Mature. Okay. But not too many, right? Not too many lymphocytes. Okay. All right, let's look around and see what we have here. So there is a lot of this distracting epithelium, respiratory epithelium. Yeah?
Yes.
It's very distracting. Not a good sample. Not a good lymphoid sample anyways. Lymph node sample.
Where is the sample picture?
Because I'm seeing all this respiratory epithelium, I'm saying this was during a bronchoscopy procedure and they went through bronchial, like a lymph node. Perhaps it's a mediastinal node, but they went through a bronch. Not a wash. Yeah, EVIS. Yeah. Okay. All right. So, but so much contamination. This is terrible. Okay. So can we even, have we seen anything bad yet? No. We're seeing a very scant population of lymphocytes. Yeah. A large population of respiratory epithelium contaminated in here. Contaminant. Yeah. Not impressed. Okay. Let's see if we have any marks. Okay. See all this bronchial epitheliums? Okay. Is it really okay? Is it?
Yeah.
How do we know it's okay?
This one is the right one. This is normal.
This is okay. I see cilia terminal bar.
Yeah.
What about this?
Have some cilia on the top one.
Yeah,
on the
and
top.
there's a terminal bar down here, cilia up here. See that? So even though they look so dark and dense and whatnot, I'm seeing terminal bars and cilia. These are probably just sitting on their side because it's packed so much on one on top of another. It looks really dark. But if I look at individual nuclei, you see they all look about the same.
Yes.
Yeah. Yeah, in here, can you see?
This sample satisfactory.
Exactly. I'm wondering, is it satisfactory because we have so much contamination? Yeah.
Yes.
No malignant cells, so nothing atypical. We could say, you know what, this is suboptimal, or we're questioning if this is even satisfactory. If they're telling us it's a lymph node, but where's all the lymphoid? It's very scant. There is some. I mean, there's lymphocytes all over in the background, but you know, for a lymph node, like you want lots,
Yes.
right? Okay. Let me see if there's any marks anywhere. It's a lot of junk. You see all this junk? It's a lot of junk. So it's like, what's going on? Let's see what's in this junk. So again, looks like carbon, junk, few lymphocytes. I don't know. It's very weird. Okay. Now I'm gonna go look for some marks because there are no marks. Great. So we can say this, we're not satisfied with the sample, couldn't we? It's suboptimal. There's not enough lymphocytes. Dr. Molu, what would you say?
I would still report on what we see.
You'd report on what we see, but would you say suboptimal?
Yeah, I would agree.
Yeah, suboptimal, very few lymphocytes, and a large amount of respiratory epithelium contaminating our sample. So I would look at imaging. Is there a mass? Maybe they missed it. What's clinical suspicion? What are they thinking, right?
Yeah.
And then see if we can make something out of this. Exactly. You know, something, is there something in here that whatever they're thinking? So actually, you know what we call this thing, and I'm trying to find something that's going to help us here. And there's no marks on this thing. They call this a granuloma.
Yeah.
What they did.
They did. And I'm wondering if we had a cell block. Let me see. Do we have 18? I don't think I have so. Would be super helpful. Yeah, but I don't have one. And yeah, this is really hard to call just on this. Okay. But there must have been something else. Okay. So that could be why it's so junky. You remember I also told you granulomas can have a very hard shell, and sometimes the needle slips off, right? It can't penetrate through that hard shell. So perhaps it's a situation like that, but still, that's not our problem. You know what? We can't make a diagnosis if we don't have good cells, right? Okay, so yeah, you can say that. Necrotic junk, right? Looks like junk, but not good. But there's nothing abnormal on here, is there? No, we're seeing lots of respiratory epithelium,
Normal.
which is normal, yeah, ciliated, and a few lymphocytes, and then this junk. Okay, so that's all we can say. We can just describe that's what we're seeing. If you think it's more some suspicious mass, then you know what? You need to use rebiopsy, use resample using some ultrasound guided help, right? Does that make sense? But now you understand what paucicellular looks like. Yeah, few cells, and not only that, we've got all this heavy respiratory contaminant. Okay, so yes, sometimes it can look like a 2-cell population, and absolutely yes, there is a 2-cell population, but our second cell population is normal, bronchial cells. See that? Okay, everybody comfortable with this? Any questions about this? No?
Maybe canalization to lung.
Hmm?
Canalization to lung.
Sorry, what?
Which was a fistula.
A fistula.
Fistula.
Does that happen? A fistula? Not usually with lung. Not common. Not common in lung. Sometimes abdominal fistula. Yes, that can happen, but not common with lung. But a needle goes through lung, right?
Oh, yeah.
So this is what they've done. They picked up a lot of lung tissue here. Okay. All right. Everybody okay with this
Yes.
sample? Okay, and everybody comfortable with these cells, like these respiratory cells? Yeah, and you can tell that they are all normal. I know some of them, these groups don't all have cilia, but you can see some on the edges. Yeah, and actually some have terminal bars. Yeah. Okay. So everybody comfortable with that? And see, these guys also don't have cilia, but you can sort of see their columnar. Look like these guys. They've just lost their cilia somewhere. Yeah. Okay. So all good with this? Okay. All right. Let's do one more. Let's do this one. Number 17 is a lymph node. Left neck. Okay. A lymph node, neck node. All right. And what about patient information? Oh, maybe we don't need anything. What was that? I heard a whisper.
Macrophages.
Huh?
Macrophages.
Macrophages?
Macrophage.
Yeah. Keratinized cells. Yeah. Yeah, there are maybe some. Is that a macrophage?
A little bit vacillated.
Squamous. Yeah. Yeah. Yep. As soon as you see keratin, and you see keratin debris. Yeah. Even small miniature squamous cells like that, which don't look bad at all, but should they be in a lymph node? No. See, even that one, it's staining blue, but it's, yeah.
What bothers me in this one is low power.
Yeah.
When you get the sample, the whole keratin.
Yes. Yes.
And now she just an epidermal cyst.
Ah,
All of us have seen it.
epidermoid cyst.
Yeah.
Yeah.
Or is it now metastatic squamous?
Yeah. Another thing in the neck, you also have to think about is a branchial cleft cyst,
Yes.
right? Or a thyroglossal cyst.
The lining of the cyst.
Yes, that, what's the word? What kind of lining?
It's squamous.
Yeah, it's squamous cell lining, but it's, what is it? They're germinal, not germinal, but they're from
The embryo.
embryonal, yeah.
Embryonal.
Embryonal remnants.
Yeah.
Yeah.
Yes.
Or something. Yeah, so those can also have miniature squamous cells, but they should not have abnormal looking squames or even keratin debris. They're usually nucleated squames, right? And it usually has a dirty background because it's like long-standing. It's been there for a while. Yeah.
Yes.
Anything else? Something else I'm missing here? Or can they have anucleate squames? Those thyroglossal duct cysts. Do you know? Does anyone know? Squamous epithelium, right? Okay. So when we look here, can you see these nuclei? It's not normal. Yeah, not normal. So here's a small pycnotic squamous nucleus.
Good.
It might look okay, but look at these other ones, right? High NC, kind of open chromatin. I think maybe small chromocenters or maybe even a nucleoli, right? So if I'm starting to look at these nuclei, I can see too much atypia. Yeah, too much atypia in these squames. So yeah, it rules out that branchial. Oh, look at that. Look at that tadpolish. Look at that one. Wow, right? Very atypical. So now this makes it at least suspicious of squamous CA, if not squamous cell carcinoma. Yeah?
Yes.
Everybody good with this?
Which is simple as sticker on front, so it is interesting.
Exactly. But sometimes, it says neck node. Neck is a really funny site because neck, sometimes it can be salivary gland. It could be thyroid. It could be
Muscles.
muscle.
Muscle.
It could be,
No.
yeah,
Measles, hemangioma.
because yeah, there's
Thank you.
so much happening in the neck, right? Thyroid, like any of those. So when they say neck, you always have to think a little bit outside the box because maybe they say lymph node neck, but maybe it's just a mass. Exactly, right? Do you find that too?
Bronchial cleft, tuberculosis.
Exactly,
These are sort of things.
exactly, right? So yes, you gotta think a little bit outside the box when it says neck FNA, right? They might think it's a lymph node, but it could be something else. So always kind of have an open mind when you look at neck. Okay, all right, so everybody comfortable with this one being squamous cell carcinoma? Yeah, and not anything else, right?
Yeah.
We have some pretty bizarre squamous cells in here. The nuclei are pretty crazy.
Nasopharyngeal carcinoma.
Nasopharyngeal carcinoma, yes. Can that happen in a neck, Dr.?
Yes, that can have metastatic carcinoma to lymph nodes.
Nasopharyngeal. But nasopharyngeal usually is a very high-grade squamous carcinoma. Is it? Or can it look like this?
There are variants.
Oh, are there variants? Oh, okay,
There
okay.
might be non-keratinized or keratinized.
Ah, okay. So but it's more of a high grade?
It's usually, I think.
Usually high grade. Okay, but it can present like this
Yeah.
with keratin? Okay. Thank you. Yes, there's a good idea too. So nasopharyngeal is another one with, that's usually Epstein-Barr virus positive as well, right? So, okay. All right. Very good. Yeah. Great. Okay. So everybody comfortable with this case? Yes, friends. Okay. See what this one had. I don't think we looked at it. Again, it's just a random lymph node and no other info. Oh, this is a cell block. Huh. 4L. Okay, mediastinal 4L node. Yeah. So probably again EBUS. What's EBUS? What does EBUS stand for? EBUS. US is ultrasound.
Yeah.
EB endobronchial.
Yeah.
Ultrasound. Yeah, usually during bronchoscopy they take these. Okay, what's are these respiratory cells again? Because they went through lung.
Maybe reserve cells.
Oh, reserve cells. This is quite a thick, almost a papillae. Yeah? Would reserve cells do this? Not usually. Are they little papillae of endobronchial cells, like a respiratory epithelium? We just saw some on the other slide, right? Groups. Are these that kind of cell? Where's the terminal bar and cilia?
No.
None.
Yeah.
No terminal bar cilia. Okay, what does that tell us?
It's not benign.
This is not
not-
the normal
not right.
respiratory epithelium. Yeah? Okay. So, all right. Interesting. A lot of very tight groups. Any thoughts? There's a little lateral group.
Metastatic papillary neoplasm. Maybe.
Metastatic papillary neoplasm. Interesting. So yes, it does look quite papillary, doesn't it? especially that other group we looked at, well, even that one and this one here, especially tip of a papillae. Yeah, see that? Smooth edge everywhere except where it got broken off. Tip of a papillae, right? You see that? Everybody appreciate that? Yeah. Okay. Is there a particular location these papillary neoplasms can come from? This is 4R. 4L, sorry, 4L. So it's a mediastinal.
Biatry.
So pancreas, pseudopapillary neoplasm of pancreas, I don't know. Can it
Pancreas, one.
metastasize?
Yeah. Okay. One option. Anywhere else? So this is a
Thyroid.
thyroid. Yeah, that's another one. They get papillary neoplasm, and yes, this is nearby, right? Paratracheal.
Yeah.
Anything else? So what's this background look like? Let's look around at the background here. See, these groups are everywhere. Yeah. Small little tips of papillae almost.
Around this in the machine.
It's a little hemorrhagic. Yeah, dirty, isn't it? Dirty background. And look here,
Terminal.
terminal body.
Terminal body.
So there's your respiratory sac. And you can see, do these look the same?
Yes.
Mm-hmm. Yeah, another one up there. Yeah, this one is a nicely
yes.
ciliated too. But you see, these cells all look a bit different, right?
This plastic of this respiratory cell, maybe.
Abnormal respiratory cells.
Yeah.
Could that be a possibility? A papillary neoplasm from the lungs?
Yes.
Does that happen?
Yes, that's
Good. It's good, right? Yeah. Like an adenocarcinoma?
yes, we have papillary variant of adenocarcinoma as well.
Right. Okay, so we have a few things on the table. Very good. Awesome. Any immunos we can do to help us out?
Yes,
Yeah. TTF1?
TTF1, CK.
Yes, right. Sorry, we didn't catch that very well.
Yes, TTF1 and CK and
Yes.
F
Okay, yeah.
thyroid globulin, I think.
Okay. Right.
And then for pancreas, CK19.
Okay. Very good. Anything else, Dr. Molu, you want to drop in here? That's pretty good. Excellent. Yes. And so everybody's comfortable. So even these nuclei, so if you know, for thyroid papillary carcinoma,
Nuclear features are
nuclear
not
features are lacking. Yeah, those, right? These nuclei look very black, very round, but still something is wrong with them, right? So yes. So it doesn't quite have the thyroid PTC, but I think still we need to just make sure and rule it out. Yeah. Would TTF1 be positive if it was a thyroid?
Yes.
Yes.
Yes, that one is also.
Yeah.
From lung, that is also.
Also TTF1, right? So yeah, we might have a little bit of a Anyway, history, perhaps some imaging, CT, if there's some mass somewhere, that might help us out. But everybody comfortable with this being a definite second population of cells which are now abnormal, right? Yeah. Okay. Good. Endothelial cells. Little tangle of endothelial cells next to this thing. Cluster. Okay, very good. Let me look at my answer, see if I know. Oh, wait, let's look at the cell block first. So we have a cell block on this thing. Ooh, Again, little
Granular gland.
papillae-like things. Wow, lots. So beautiful block. We can do all kinds of immunos. Not in Afghanistan though. But yeah, anything we see here that is different or still look the same?
No, there are some gland formation here, which is not
Ah,
appreciable on that one.
Exactly, yes. Looks like little gland formation. So more suggestive of an adeno. Is that what you are saying, Dr. Mushtaba?
Yes, yes.
Yeah, right.
I think those server is a nuclei now.
Yeah.
Now let's look at the,
No. No. Compact nucleus.
still some look
Done.
very compact, very uniform, very round
No group.
edge.
Oh.
So now when you see this, what do you think? It's better.
Could a low-grade adeno present this way?
Even they are not looking dysplastic.
So what are you thinking, Dr. Molu?
I was thinking, could it be a neuroendocrine?
But they are very papillary, aren't they? This is quite papillae-like
And columnar like.
and
low
columnar-like,
low
low columnar, yeah.
like
Yeah, look at some of
Are
these.
they clear cells as well? Because it have a sense of clear cells
Yeah.
as well. I don't know. Is it the monitor thing or
yeah, that's
Ah.
what this one is
very
nucleus
clear?
here.
Yeah, so you see, I see intranuclear, like almost this thing.
Yeah.
Inclusion. Small nucleoli here, I can see. Huh. Yeah, the cytoplasm, would you guys say it has some,
Abundant cytoplasm.
yeah, it looks like pretty abundant.
Yes.
In some areas does look a little bit clear. Some areas more eosinophilic.
Granular.
Yeah.
So I
Yeah.
would add to the metastasis that not Dr. Morta by suggesting the clears.
Clear cell carcinoma.
Kidney and
Kidney, yeah, and they can kind of look like a
hepatic.
papillary, glandularish looking, yeah. Right. Very good point. Great observation there, Dr. Murtaba. Mushtaba. Oh my God.
Thank you.
Okay. Okay, very good. Now with renal cell carcinoma, if it was, you would also see like endothelial nuclei. Yes, no? Renal cell? Clear cell? Maybe. But yeah, definitely good to add to the differential. Yeah, it's definitely got a very papillary look on this thing, eh? Okay. We got a bunch of differentials. Let's see what we call this thing. 16. We call it metastatic adeno prostate primary.
Oh, yeah.
Primary mucus.
Prostate primary. Yeah. We just said metastatic adeno on cyto, which is
It is
yeah,
adeno.
absolutely.
Yes.
But the
Prostate.
primary is prostate. So again, they probably did immunos on this thing. And yeah, it was a 78-year-old male. Okay, there we go.
The
Yeah.
lymph node was very far, that's why our differential was.
Yeah, we were being safe, right? Yeah, but we did go renal cell actually, which was also far. But no problem. Okay, good, very good. So yeah, we got some very good conversation there on that one. Okay, did you want to look at some more anything?
Just to look at a couple of cases that stop.
One more? Two more maybe? Let's see how we do here. Okay, let's look at this thing. A neck node. Here we go again, neck. So, ooh, look at this.
Aggregation.
So many groups. Are they
Hypertrophy.
normal?
No.
No, these are again papillary.
Papillary,
Groove,
yeah.
groove clearing.
You see a groove.
Yeah.
You
too much
do?
groove.
Yeah,
Too many grooves.
inclusions are there, clearing and
Really? Oh my God, we nailed it.
PTC.
You see all the grooves here. Everybody see them.
Yes.
There are like a million grooves in this one group here
Yes.
by itself. Where's the inclusion, you guys?
But the trailer club 370.
In the same group?
Yeah, either here.
Trio.
This and this one, isn't it?
In this group? 3 o'clock. Oh, lower. Here? Down here? Lower is this. Ah, here.
Yeah. Yeah. this-
Inclusion.
Ah, there's a good one here. Look. Sorry, maybe
This
somewhere
one is
else
also-
too. This an inclusion?
Yeah.
Yes.
And the bottom and this direction also, this two cells. The upper one, this one, the upper one.
Yes.
Yeah. Not great, but
No.
yeah, it's kind of
Group.
starting.
Or
Yes.
not inclusion.
It's
if
it's
group.
iffy include. Yes,
Yeah.
for sure. Okay, very good. Look at that. We didn't even have to go far. Here maybe another inclusion up here.
Yeah.
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 Lots of grooves everywhere.
Mm.
You don't have to even look very far. Okay.
this lymph node have that papillary feature and all other things to be confirmed the PTC, but there is
Exactly.
there is an important point
Yes.
diagnosing the lymph nodes which are near to thyroid gland,
Yes.
middle to sternocleidomastoid, because thyroid gland parenchyma can be engulfed by normal lymph nodes and sometimes we can see thyroid parenchyma in lymph node, and
Yes.
that's a benign condition.
Yes, and you can see like a normal lymph node tissue in the middle of a thyroid. Is that what you're saying?
Yes, vice versa, and
And
the thing
yes.
that you said.
Right, exactly. And here you remember how we said a nice smooth edge. Look at that smooth edge. This massive little, massive papillae kind of thing. And do you see like almost looks like a extruding central core here. Do you see that on this thing? Here, see the central core here, extruding out of this big chunk of papillary group. So yeah, all those things we mentioned. So flat macrofollicular architecture, papillae, crowded groups, variable sizes, not round anymore, they're elongated. Look at all the grooves everywhere. So you see all those features we talked about on when we did thyroid. We're seeing almost all those features here. Yeah.
Yes.
And yes, very good point that Dr. Mushtaba made as well is the, lymph nodes near thyroid. Yeah. Okay, very good. Nice. That was easy. Fast. Oh, look, what's this?
Yeah. This.
What's this pink thing? The colloid.
Colloid.
Nice little blob of colloids.
Thick.
Yes, thick colloid. That. No cracking, but it's colloid. Yeah, excellent. Okay. Yeah, more
The
colloid.
screen will be off for 20 seconds.
Oh boy.
It's a long.
Oh no. Do something. Please fix it. Okay, very good. So we're comfortable. This is PTC, metastatic. And it was. Yeah, very good. Excellent. We'll do one more now, seeing as we are on a roll. Let's see. Just look at this. Ooh, submandibular lymph node. Okay, submandibular lymph node. Do we need any patient history? 66 male. Okay. Oh. Okay, so we have a large chunk of something. Hmm,
This.
wow. Oh, do you see anything in here? I don't know about the online people, but you guys should appreciate something in here. Yeah.
Optimization.
Yeah, look at the ring. Can you see the rings in there?
Yeah.
Multiple rings. More.
Again, yeah.
Hmm. Nucleus up there. Mhm. Wow. Look at those rings, eh? Can you see them? They almost look like samoma bodies, but they're not. Yeah.
Yeah.
Rings, keratin rings.
Grassy.
Glassy, yes. And this is like keratin debris. Look at that, see? Wow. 3D chunk of keratin.
3D pearls.
Yeah, 3D pearls. Except there's no nuclei. Well, there's a few nuclei, but yeah, pearls usually have very little nuclei. Excellent. Okay, so right now, submandibular lymph node. Squamous cell carcinoma or epidermoid cyst or what?
Then you worry about your
Mucoepidermoid.
Yes, mucoepidermoid is a top differential.
Yeah. So does mucoepidermoid has a bit of a like a cystic background? Yeah.
Yes, mucinous and cystic.
Mucinous, cystic, and then you get some squamoid kind of cells, and you also see
Multiphasic cells, clear cells, basaloid
yes,
cells,
yes,
squamoid cells.
yeah, mixture.
One of the consultants I work with said, if you get keratinized cells, it's not going to be mucoepidermoid because mucoepidermoid never gets keratinized cells. So
Huh?
if it was salivary gland tumor, the keratin, even on histology, if you see keratinized squamous cell, it's very likely a metastatic squamous cell
Rather than a
primary
mucoepidermoid. Ah, did you hear all that, Dr. Mushtaba?
Yes, yes, thank you.
Oh, okay. Yeah, perfect. Thank you for sharing that, Dr. Molu. Okay, excellent. So most likely Mets squamous cell, right? Rather than any other option. Yeah, everybody okay with this? Or do
Yeah.
you need to see some really abnormal squamous cells still? Which would be nice. Would be nice, but we're suspicious for squamous, and
This
here
one.
are some nice, well-preserved squamous cell nuclei. And here, look at those guys.
The
Okay.
bottom one is bigger.
Yes, yeah, lots of atypical nuclei in there. Okay, very good. So another nice one. Okay, are we good? We can end here. Yeah,
Yeah.
call it a day.
Thank you. Thank you very much.
Thank you.
You're welcome. Thank you for all the online docs and your contributions and discussions. Thank you.